Perfect. So, subject of my talk is anterior Petrosal approach, focusing on the anatomy, focusing on the technical steps of this approach. So, as you all know, the anterior Petrosal approach is a middle fossa approach. It's an extradural approach below the temporal lobe. Being extradural, you need to expose the petrous bone from above, and you drill through the petrous bone to have access to the posterior fossa dura. So looking at this picture, you can understand that it's a great approach to reach petrous apex extradural lesions, for example. There is not so many types of lesion like this. Chondrosarcoma is a good example, but it's also a great approach to access the posterior fossa from an anterolateral angle. This is a drawing from one of my previous fellow, Kentaro Watanabe, showing this line of sight going through the petrous apex below Meckel's cave and a little bit anterior to the internal auditory canal between two sinuses, superior petrosal sinus, inferior petrosal sinus. There is a kind of mistake in this drawing because it gives you the impression that the superior petrosal sinus is big and the inferior is small. It's exactly reverse. The superior petrosal sinus, in fact, is not so big in this area, but the inferior petrosal sinus can be an issue during this type of surgery. This is another cartoon from Kentaro showing that it's an extradural approach. You have to peel the dura from the temporal fossa floor. You expose Kawase triangle, find the landmarks, and you start to drill the petrous apex just like you would drill an anterior clinoid through a frontotemporal approach to expose the posterior fossa dura. You open it and you have a great access to the exit zone of 5. So what is the advantages, in my opinion, for this approach? First, you don't cross the nerve compared to the retrosic, for example, to reach petroclival lesions. It's an anterior line of sight. So for brainstem cavernoma, some of them, I really feel that it has some advantage to really get to the deep part of the cavernoma, which is sometimes close to the floor of the fourth ventricle. It's an extradural approach. So if you are treating a meningioma, you reach the dura first, so you can devascularize it first prior tumor resection. When there is a lot of feeders, when it's a bloody tumor, it definitely can be an advantage. It exposes Meckel's cave, so it's nice for tumor into Meckel's cave. It exposes the mid-clivus, and I don't see the end of my slide. Oh, yeah. And it gives you a contralateral visualization and an anterior view of the brainstem and its perforators also, and branches. Disadvantage, it's a kind of bloody approach when you peel the dura from the temporal fossa floor, because there is venous channels, venous plexuses going through foramen ovale that are usually bleeding. It's quite easy to control, raising the thorax to reduce venous pressure, using flow seal, which make it much easier since we have it, and tamponade and waiting a little bit, and usually it stops most of this venous bleeding. You have to be careful because sometimes some important vein drain in this area through pterygoid plexus, through foramen ovale. It can happen. So taking a look on the venogram, especially on the left side, is important. Brain retraction is important and can be a source of complication because you have to elevate the temporal lobe a little bit. So playing with intracranial pressure is extremely important, raising the head, using mannitol, draining CSF. This is a fantastic picture from Albert Rotten showing this temporal fossa floor from above. You have here trigeminal nerve with the third division. Here you have carotid artery, GSPN, foramen spinosum, and here the superior petrosal sinus. We can see here air cells above the middle ear. This is after drilling the bone to show you the anatomy behind it. You have here the internal auditory canal, superior semicircular canal, greater petrosal nerve, carotid artery. The cochlea is hidden below geniculate ganglion, below the junction between geniculate and GSPN. So the cochlea is always deeper than what we think. It's a fear that we have with this approach at the beginning, but in fact, the risk of getting into the cochlea is not so significant because it's deeper than what we think. What are the indications for this approach? Petrosapex tumor, chondrosarcoma, chordoma, cholesterol granuloma, no more in my practice because now I do it endoscopically on some bone tumors. It's an approach for Meckel's cave tumor, trigeminal schwannomas. We had some great example from Professor Gold just before. Petrosapex meningioma, sometimes when it's going quite deep into the brainstem, pushing the brainstem posteriorly, it can be interesting to have a more anterior line of sight. It's part of the approach for some petroclival meningioma, sometimes alone when the tumor is not too low, but sometimes combined with posterior petrosal. And it's a nice approach, in my opinion, for some brainstem cavernoma. It's very important to look at your preoperative workup carefully because most of the issues that you can have during anterior petrosal approach, you can find the solution, you can prepare yourself for difficulties just by looking the CT, the MRI very carefully. This anatomy is hidden below the bone, but CT give us the opportunity to see it before. So shape of the temporal floor, arcuate eminence, relationship with the superior semicircular canal, how pneumatized is the petrosapex, is there air cells in the zygoma? If you cut the zygoma, you may open it. If you don't figure it out, you can have a leak post-op just because you forgot to put bone wax in this area. It's important to know if there is bone over the ICA. Sometimes it's very rare. You may have superior semicircular dehiscence. If you peel the dura from it, you can create some hearing loss. And most important is to look if there is some bone over geniculate ganglion, because again, peeling the dura, you can injure geniculate because it's not covered by bone. So to me, this is the best neuronavigation system ever. It's quite cheap. It's just a CT scan. If you look at this pneumatization on the petrosapex, it's a roadmap. You get into these big air cells medial, then you move to the one more lateral, then you move towards the cochlea. You can navigate into those air cells. So very important to look at this before. It's the same if there is no air cells, but cancellous bone. You have this cortical bone that is your limit here, and this is cancellous bone. Sometimes it's very soft. And you move laterally, when you start to see hard bone again, it means that you are not so far from the cochlea. Here it's show you the depth of the cochlea. This is an information that I always look at before doing the case. How deep is the cochlea? Sometimes it's 1-2 millimeters, sometimes it's 5. And it's important to know because it defines the risk of injury to the cochlea. This is an example where you see geniculate. And you see the cochlea is very much below. And your line of sight with retraction of the temporal dura, in fact, never cross the cochlea. So this situation is quite safe. Here is a case of dehiscence of the superior canal. What is the position? Supine or lateral position. I prefer supine position with elevation of the shoulder. Quite a lot of rotation. That's why you need to elevate the shoulder. 80 degrees, I think is nice. Question mark incision, I monitor 7 always. You may monitor other cranial nerve depending on the situation, MEP, SSCP depending on the pathology. I'm not using lumbar drain anymore because the CSF for the extradural approach, I think is a great protection for the brain. If you remove CSF before elevating the dura, when you manipulate the dura, it's the same as manipulating the brain. It gave you the false impression that the brain is protected, but punching the dura is punching the brain and there is no CSF protecting the brain. So rotation is important, but it depends on the pathology. This is a case where there is definitely too much rotation. And if you want to adjust, you will have to bend your neck to look at the tumor. So you have to adjust the rotation to the direction you really want to reach the lesion. This is extremely important. It starts with soft tissue dissection. I start with interfacial. I don't remove most of the time the zygoma. If I really need to go up sometimes, but it's not so often. Retrograde dissection of temporalis muscle, and the bone flap needs to be anterior enough. This is a video showing you the first step of the surgery. Question mark incision. You elevate the skin flap, and nothing special with it. And then you need to mobilize the temporalis muscle. I don't like to cut the fibers of the temporalis muscle too much. You need to expose here the root of the zygoma. It's very important. If the root of the zygoma is not exposed, you may not be anterior enough. This is why I do also interfacial dissection to retract the skin more anteriorly. And here I incise the muscle just above the zygomatic root and the retrograde elevation of the temporalis muscle to keep this periostal layer deep intact, to keep the muscle intact, to keep vessel and nerve. It's like the pterional approach, but it's going a little bit more posterior above the root of the zygoma. Once you have done this, you do the craniotomy, nothing special about it. Resection of the zygoma, either a small cut on the zygoma or this chicken bone zygomatic resection that give you the advantage of being able to retract the temporalis muscle more anterior. It's nice when it's more a cavernous sinus tumor, for example. Then you need to elevate the dura from the temporal fossa floor. You elevate going from back to front, gentle traction of the dura. You have to be careful with geniculate ganglion if it's not covered, and you progressively identify your landmark, subarcuate eminence, posteriorly, foramen spinosum with middle meningeal coming out, and a little bit more anterior and medial foramen ovale. Once you have this, you cut middle meningeal, and you can peel the dura a little bit more medially to find GSPN. How to find GSPN on geniculate? Stimulation is mandatory. You need to stimulate at quite high power at the beginning, and the closer you get from the GSPN, then you lower the stimulation to find the threshold. This is the landmark, subarcuate eminence here, foramen spinosum with middle meningeal. It's important to be aware that arcuate eminence do not always correspond to superior semicircular canal below it. This can be envisioned and prepared looking at the CT scan. Section of the middle meningeal, you coagulate and cut. I leave usually a few millimeters of middle meningeal, and then you find GSPN. GSPN is usually embedded into a little bit of periostom or connective tissue, so it's not always clear. And you have to be aware that there is an angle between GSPN and carotid. GSPN is not exactly parallel to carotid. You need to avoid also to avulse GSPN from geniculate ganglion. This is why you need to elevate the dura from back to front, posterior to anterior. But if you're too strong, elevating the dura from back to front, you can also tract GSPN away from geniculate ganglion. And I had one case where I had some response of the fascial nerve doing this, and the patient had a transient fascial palsy post-op. Looking at this temporal fossa floor, where is GSPN? Not so easy to say. Is it here? Is it here? Is it here or here? Only stimulation can really conclude and tell you that GSPN in fact is here. So once you have fine GSPN, you need to elevate a little bit more the dura, and you have to separate the dura from the V3. Because if you don't do that, and if you tract on the dura, you will also tract on V3. So you need to peel the temporal fossa dura away from V3, doing a small incision of the periostom along foramen ovale. It's the same principle of peeling of the lateral wall of the cavernous sinus using Akupa or Kawase technique. This is a cartoon to show you that. In red, it's periostom. In green, it's temporal fossa dura. You elevate the dura from the temporal fossa floor. You drill a little bit of bone along foramen valley. You cut this bridge of periostom and you keep going with the elevation of the temporal fossa dura from B3. And it gives you additional exposure of the temporal fossa floor more medially. It gives you the ability to reach the petrous ridge more medially without too strong retraction. Retraction is an important issue. How to retract? At the beginning, I was using a retractor like this. I stuck the retractor behind the petrous ridge. I have to say that now I am not using retractor anymore. I am using stitches on the dura and I use dynamic retraction. I think it's better, it's safer for the brain. And in fact, you don't really need those retractors. Just retracting the dura with your suction. I like to feel this pulsation of the brain behind my suction. For this, you may need lumbar drain. As I said, I'm not using it anymore. You need to evacuate CSF with a small incision at the beginning of convexity, like this. Progressively, CSF goes out, drops after drops. You need good anesthesiologist, and you need to be careful with the position head up. So this is what we expose. The Kawase triangle, limited by V3, limited by GSPN, limited by subarcuate eminence and petrous apex. 3 areas of drilling: premeatal corridor, meatal above internal, auditory canal, and postmeatal triangle. And this is defined by landmarks, GSPN, and you have the cochlea below the bone, and you have the superior semicircular canal, not always completely below subarcuate eminence. There is an angle between GSPN and internal auditory canal, 60 degrees, and you have a vertical line between external auditory canal and internal auditory canal, but this depends on the rotation, obviously, so it's not very reliable. So how to drill? I start to drill usually very medial, a little bit lateral to Meckel's cave. And then progressively I move forwards. Once I am in the cancellous bone, I move forwards towards the carotid. You don't need to completely expose the carotid. Depends on how low you need to go. The lower you need to go, the more lateral you need to drill. Then I move back to the cortical bone of the posterior fossa, and then I move forward towards the internal auditory canal. It's very important to understand that between 3 and 4, there is not an acute angle. It's very smooth transition between the posterior surface of the petrous apex and the anterior surface of the internal auditory canal. And then I drill more towards the cochlea. This is what usually beginners are afraid of. But again, looking at the CT scan preoperatively, the depth of the cochlea gives you additional information to do that safely. And if needed, you may drill behind internal auditory canal, postmeatal triangle. It's a little bit tricky area to drill because you have superior semicircular canal just in front. And finally, you need to drill the petrous apex, the true petrous apex. The true petrous apex, in fact, is below Meckel's cave. And for petroclival meningioma, for example, it's extremely important to drill this area because this really will allow you to coagulate the medial clival artery, for example. And finally, if you want to get closer from the cochlea, really to have a lower exposure into the CP angle, into the prepontine cistern, it's a little bit tricky. I personally follow the labyrinthine portion of the facial nerve, and then it gives me the position of the cochlea. This is how I get very close to the cochlea. But again, this is rarely necessary. Postmeatal drilling, why do you need it? You need it maybe to go more laterally and to have exposure of the middle cerebellar peduncle, and it gives you also a better exposure of the cisternal segment of 7 and 8. Then you need to open the dura. Open the dura, you can make an incision on the temporal dura parallel to the superior pectoral sinus, incision on the posterior fossa dura of the petrous apex, and then you have to cut superior pectoral sinus and to cut the tentorium. It's better to cut superior petrosal sinus as anterior as possible because you may keep the drainage of the superior petrosal vein. It's not always possible. Depends on the anatomy, depends on the pathology. Usually, sometimes in petroclival meningioma, it's already occluded, but this, again, you can look at it on the MRI, MRV before or angio. Cutting the tentorium, neuronavigation is nice here because it's not always easy to understand the direction, where to go. If you go too anteriorly, you can cut forward. If you go too posteriorly, you may not find the free edge because you will cut behind. And at the end, this is the exposure. You have the exit zone of 5, and you understand here that if you want to open Meckel's cave, you just have to keep incising here, making an incision here along V3 to open Meckel's cave like a book. What is the morbidity, potential morbidity of the approach? Temporal lobe, if you're not careful enough with your retractor or even with your dynamic suction, thinking that behind the dura there is nothing, you may create contusion of the temporal lobe. Seizure, I had 2 cases of seizure during the surgery when I was using lumbar drain, and this is why I stopped using it. It was not injury of the brain on the post-op MRI, but I think the irritation of the brain with movement of my suction on the dura directly transmitted to the brain because there was no CSF anymore, created those seizures. Temporalis muscle atrophy, TMG disorder, CSF leak, facial nerve palsy with injury to the geniculate, hearing loss if you open semicircular canal. Show you 2 or 3 cases. This is a cavernoma of the brainstem. I like to use anterior petrosal because this cavernoma is going quite far back posteriorly. This is a video of it, incision like before. I'm gonna go faster. Here is the interfacial dissection. Again, to retract the skin flap more anteriorly. I expose here the root of the zygoma. It's very important because it gives you anterior exposure. If you don't expose it, you may be too posterior compared to your target of the anterior petrous bone. Here is retrograde dissection of the temporalis muscle. Here is above the zygoma. You really need to peel the muscle from this gutter formed by the zygomatic root. Here, in this case, I cut the zygoma. As you can see, this allows you to retract the temporalis muscle lower and more anteriorly. This is here the bone flap. Closing air cells here on the root of the zygoma. Section here of the middle meningeal artery. I leave a little bit of artery distal. Here is elevating the dura from V3. Now elevating a little bit the dura from V3 and from Meckel's cave also. You can start to see the position here of GSPN. There is venous bleeding, but you can control it again quite easily with Surgiflow or Flow Seal. It was a case where I was still using a retractor, but you know, anteriorly, I don't have one and I put stitches. I start the drilling medially and then move progressively laterally towards the carotid artery. Here back to the posterior aspect of the petrous bone and drilling more posteriorly towards the anterior aspect of the internal auditory canal. This is here above the internal auditory canal towards the posterior meatal corridor. A little bit of CSF, it's always helpful. Now is incision of the dura, section here of the superior petrosal sinus, incision here of the sinus after putting 2 stitches, connecting to the incision of the posterior fossa dura. And then cutting the tentorium towards the free edge. Using the navigation here is nice. And I start to see here the root of 5. Root of 5, and I will do my incision for the cavernoma, I believe in this case a little bit above, small incision on the brainstem to get into the cavernoma, resection of the cavernoma. Okay. That's, I will, this was a case of petroclival meningioma, but it was not going very low. So I did an anterior petrosal approach. It was also nice because a lot of tumor were into the petrous apex. The only thing I didn't want it to do in this case is to open sphenoid sinus. So I left a piece of tumor here because I didn't want it to enter sphenoid sinus and with a risk of leakage. I skipped the video, but it was a perfect case for an anterior petrosal approach. This was a nice case of chordoma. Chordoma quite lateral. This patient had a transient 6. I didn't want it to go endoscopic because it was purely cisternal. And also I was afraid of injury of 6 with an endoscopic endonasal approach. So here I did anterior petrosal approach, and then I used the endoscope for the lowest part of the tumor because it was going quite low, below the internal auditory canal. And if you read textbook and articles, it says that below internal auditory canal, it's tough to reach. Yes, it is, but it's without using the endoscope. With the endoscope, you can look down below internal auditory canal and have control of the tumor. If it's a little bit soft, like chordoma, in fact, it's very nice. So here is looking with the endoscope. You can see the 6th nerve. This was the maximum, my inferior limit with the microscope, but putting the endoscope inside, I had a quite nice control of 6 that was quite adherent to the tumor, but careful elevation of 6. The patient had a 6 post-op, but he recovered after a few weeks. I don't think I would have had this kind of recovery going endonasally. I switched the endoscope to look at the clivus to remove the part of the tumor into the clivus because there was still a little bit of infiltration of the clivus. Chordoma comes from the clivus. What else? You know that anterior petrosal can be combined to combine posterior petrosal to have a combined petrosectomy. This is a case of combined petrosal here that I did for a chordoma case that was going quite widely into the subarachnoid space with a part into the cavernous sinus. I did a 2-stage surgery. 1 stage for everything that was extradural, and another stage for what was intradural. So here is a video of it. So this is the exposure. Do you hear me? Yes?
Yes.
Okay.
Yes, yes.
So this is the exposure, classic exposure of a combined petrosal. I have a specific incision for combined petrosal approach. Here is a bone flap. It's a kind of mini combine with cosmetic mastoidectomy here. So mastoidectomy, posterior petrosal approach. I go fast on this. And once you have done that, you combine it with the anterior petrosectomy. Here I have a little bit more posterior line of sight compared to the pure anterior petrosal, drilling here the petrous apex, exposing the posterior fossa dura, drilling above the internal auditory canal. This is the final exposure. No need for retraction here. Incision of the dura is a little bit different here because you need to mobilize the transverse sinus completely. This is what gives you, in fact, the corridor of exposure. Okay, I think I stop here because I am running a little bit late. So in my opinion, anterior petrosal approach is extremely important approach in skull-based surgery. It's true that if you're not a skull-based surgeon, the opportunity to use this approach are not so much, but there is a lot of indication, as I told you at the beginning of my presentation. Knowledge of the anatomy is absolutely necessary, and I strongly believe that this is typically an approach for which you need some training in the lab. Again, like any skull-based approach, the final goal of it is to protect protect the brain, not to drill the bone. You drill the bone in order to protect the brain. So it's an approach where you constantly need to keep in mind that you are below the temporal lobe, and the structure you want to preserve is the temporal lobe. Thank you very much.
Thank you, Sebastien. Wonderful presentation. There is no, I don't see any question on the chat. So
sorry, there is one question by Alessandro Melatinini, I think from Italy. He is asking about the petrosal sinus injury during the exposure. What do you do? I think you mentioned it, but if you just summarize it in one line or two line, Sebastien.
For the petrosal, superior petrosal sinus or inferior petrosal sinus?
Inferior.
Inferior, I try to avoid it because, again, it can bleed significantly. If it's a petroclival meningitis, not so much of an issue, but if it's a cavernoma, yes, it can bleed significantly. I try to use Froelich, but not too much, because you can inject a lot of Froelich and have issue with all this Froelich into the venous circulation. So it's a little bit of Froelich, Surgicel, and tamponade.
Thank you.
Hi, Giovanni, can I ask a question?
yes, please.
Sebastien, thank you. Great talk as always. And I really enjoyed the bit about planning the whole operation through your CT scan. Can I just ask, because you combine endoscopic and open approaches a lot like we do, and do you think the location, even in soft tumors, in relation to the carotid artery really matters? So the tumor is behind the paraclival carotid or lateral to the horizontal carotid, would you favor an open approach, or do you, even in soft tumors like chordomas and chondrosarcomas, a bit of drilling is required, would you go endoscopically? So the relationship of the tumor to the carotid artery in the petrous bone.
It's not so often now that for petrous apex tumor, I go with an open approach, in fact. Petrous apex tumor like chondrosarcoma, for the vast majority of it, I go endoscopic endonasal. And with angle instruments, angle endoscope, in fact, you can go quite far up to the internal auditory canal. It's just a question of having the good instrumentation. My indication for petrous bone tumors going open, it's when the tumor is going more laterally than the internal auditory canal. And there is some chondrosarcomas that are quite lateral, and for which purely endonasal is not good enough because it's going too far laterally.
Thank you.
Ahmad, may I add?
There is a question from Jack. Yeah, go ahead.
Sebastien, as always, masterful presentation, but just a small detail of nomenclature. You've been calling it subarcuate eminence. You mean arcuate eminence, don't you? There is the subarcuate. I don't want the young people to confuse subarcuate fossa, obviously with but you've been calling
Absolutely.
it. You agree with? Okay. So you have to correct all those beautiful slides that you have with the correct.
I thought you would mention the tubercle of Prince Otto.
That's right. Well, next time I'll explain it to you again.
Okay. Any other question?
Yes, I have a question. Yes, thank you. Thanks, Sebastien. It was a very nice presentation. Can you guys hear me?
Yes.
Great. So I have just a comment. I think the first thing is that I know that you mentioned using navigation. I think that using neuronavigation to drill the temporal bone is probably one of the best application of neuronavigation, because the temporal bone, the bone is fixed, does not move. So that certainly may help, especially when you are close to the cochlea and everything else. And as everybody knows, even a change of 2-3 degrees in the angle of approach compared to the way the CAT scan was done, that makes a huge difference. So usually when I do this approach, although of course I rely on anatomical landmark, but I supplement them with neuronavigation, and I use the focal point of the microscope as the virtual pointer. And then the other thing that I do a little bit different is that as the intrapetrous carotid artery is, of course, a very important structure, I try to visualize it quite early during, during the approach. And I usually, the intrapetrous, at least the horizontal portion of the intrapetrous carotid artery, it's not covered by very thick bone. Sometimes there is no bone, and sometimes there is a very thin lamellar, bone. And I drill all the way, posteriorly until I see the horizontal portion disappearing and going into the vertical portion. And then I can, of course, using the neuronavigation, then I am confident that I can drill everything that is medial to that. Everything of the petrosal is medial to that, because the cochlea usually it's anterior to that. So those were just two small comments.
It's a very good point. The only thing I would say about exposing the carotid artery is that personally I don't do it very often because I am always afraid to sacrifice GSPN. And for example, if you have a tumor where you will deal with trigeminal nerve, like a trigeminal schwannoma, an addition of V1 injuries that you can have with a trigeminal schwannoma on the GSPN injury can be bad for the eye. I try to preserve GSPN, but I completely agree with what you said, that having an idea on sometimes taking advantage of the fact that there is no bone over the ICA is important to visualize it. Absolutely.
Okay. Thank you. There is some other comment or question? If not, thank you, Sebastien. And we move